So today we are going to discuss an article on breast cancer irradiation, and the article is available on the Blackboard site for you to look at, or the link is there for you to look at and read along with us. If you haven't got that in front of you, you might want to maybe pause this podcast and access the article. The article is titled Alternated Prone and Supine Whole Breast Irradiation Using IMRT, Setup Precision, Respiratory Movement and Treatment Time, and the author is Veldman et al, and it's the study was based in Belgium. We have actually used the SIGN checklist as a template for critiquing this article. There are a number of different checklists that can be used, but this is just one that we've decided to adopt for this particular task. So what we're going to do is there's a group of us here, and we're just going to start by going around the room and just initially giving a one-sentence review of what we think about the article in general, and then what we'll do is have a discussion using the checklist as a template to look in a little bit more detail about the design of the study and the results. And then at the end of that discussion, we'll summarise individually again what we think about the article and whether our views have changed. So I'm going to start, just go around the room, and if we can start with Sue. Are you happy to give us just one line on what you think about the article, just about the quality? Just one line.
Right. I like the article because of the novel approach to the research method, in the way that the researchers used the same patients but used two different techniques, a prone and a supine technique with the same patient. So I quite like that.
Okay.
That idea.
David, should we come to you? What's just a quick one-line summary of what you thought about the article?
I would echo that. No, I mean, it was unusual that the same patients were in both arms of the study.
Okay.
Very few patients in the study, though, overall, which was an interesting factor as well.
Okay. I'll come next to Denise. What's your view?
I liked the paper because I felt that it had a logical flow. So the question started off at the beginning, and I felt I had a reasonable answer at the end, and sort of sparked ideas as well around the design and perhaps how that could be applied in other settings.
Yeah. Okay. Anne?
I felt that this particular study could perhaps be viewed as a pilot study because of the small number of patients that took part or were enrolled in the study.
Yeah, that's a good point. Yeah, Kath?
Yeah, I would echo what people have said. I thought it was a well-conducted study, and although there was a small number of patients, I think I would be confident that in the sort of reliability of the results because of that, although there was a few questions about possible variables that might have still impacted on those that I would consider.
Keely?
Yeah, I again would echo what Anne said. I see it more as a pilot. I thought it was really unusual that it's using the same patients. It somewhat limits the value of the study with being sort of uncontrolled, but I did think it was an interesting study. But I think it's thrown up, like Kath said as well, a lot of issues, a lot of variables, a lot of things that have got question marks over them that maybe somebody else could take on from that.
Okay. Amy, your initial thoughts?
I liked that it looked at the setup precision, respiratory movement and treatment time as well. I kind of liked the three areas it was addressing. I didn't like it because it was using the same patients.
So that's interesting.
I didn't like that aspect of it.
We might come back to that. Rob, what was your view?
I like the design, using the same patients. I think that was good. It's not unusual to see small numbers of patients in studies like this, but there was no indication of what the statistical power of the results were, and I thought there were the exclusion criteria weren't. There was no specification of that at all. The inclusion criteria would be too broad. Okay,
and my initial review of this article is it's a useful article in terms of understanding reproducibility with the two techniques. I was slightly concerned about the emphasis in the abstract around the lack of difference between the accuracy between the two techniques, and maybe we'll pick up that in the discussion, because I don't think the results are strong enough for them to say that there is equal reproducibility. So if we could maybe start with using this sign checklist, which starts by looking at the study question and whether it's appropriate and clearly focused. What did people think about whether it was a well-defined question or an objective?
Yeah. Clear background and previous studies that relate to this particular research.
Yeah. I think most people are nodding around the table. So it was clearly appropriate and well-focused objective that was articulated at the beginning of the article. In terms of the assignment of subjects to treatment groups, on the sign checklist it's about whether they're randomised, and actually the design that was used was a repeated measures design, or a within subjects, within group design where the subject acts as their own control. So there isn't randomisation as such, but actually it is a very, very strong experimental design. So it's interesting what you said, Amy, because actually it's probably one of the strongest designs that you can have, that the individual acts as their own control. Does anybody have any?
I was just going to say, I don't know whether it sort of mirrors why you thought that, Amy, because when I first looked at, I appreciate that it's a really strong design, but my immediate thoughts were about the ethics of it initially. Is that why you? But I didn't have a concern about that after I'd read the paper.
Yeah.
But when I first saw that, I was sort of just keen to find out later on, which they did report on, that they did actually plan an acceptable dose distribution for each.
Yes.
So that it wasn't going to, through doing 2 different treatments for one patient, have an impact on outcomes.
Yeah.
So is that kind of what your thought was?
From a treatment point of view, my first thought, well, my word, how did he match? How can he justify 2 different kind of techniques? And that's what kind of sprung to mind first of all.
And thinking about a patient that's got cancer and the experience that they've got is actually, you're asking them to alternate the position daily and the impact of that, and actually how easy it is for some patients.
Yeah.
I agreed with you, Denise. I thought that perhaps on the first day when a patient arrives for treatment, how they're treated and what they do on that first day sets a precedent for what they expect then. And for maybe to give somebody one technique on the first day and that becomes familiar, and then change it around and the next day they're doing something else, I just thought that from a patient perspective that might be quite unsettling.
Yeah, I think if they just come back on that, I suppose that's the difference between being in a clinical trial and standard treatment. So this is done within the confines of a clinical trial situation. So, I'm sorry.
I think just picking up on the fact of the patient concerns and anxieties, there wasn't really anything written around the patient information that was given, because you would expect that they've signed up to a trial, like you say, and that they would have had information around the differences and the risk, but that wasn't explicit in the article.
I think that's right, but that's, again, as Rob had mentioned, that's not uncommon in articles that are published in the literature, and that partly that is because of the restriction in space. In space. So I think it's worth mentioning it from a learning perspective for researchers. Obviously, that is a given almost, that the information, it wouldn't get through ethics if it wasn't.
Yeah, that was commented on. It had gone through ethics.
Yeah.
What wasn't commented on, should have been, was how the allocation of the patients. It just mentioned there was 10.
Yeah.
Where did they come from?
There were
first 10.
That's an
That's
an interesting point, and maybe we can come on to that now in terms of the sample and how they were selected. And I think it was very much and you do again quite often get this in research articles that are published in the literature of this type, that they're consecutive patients. But again, my query would be, is there an opportunity for selection bias? Because when do you start collecting that consecutive patient? Do you wait till you see a patient that you think actually they're going to be a good candidate and they're going to be accurate in a particular position? So is there an opportunity for selection bias in this kind of...
I think they did mention very, very briefly somewhere, I probably wouldn't be able to find it now, but I think it was in the discussion, they do comment on how, although they had a small sample, it was quite varied, and I think they were referring to things like the BMI
age.
and bra size. So it did make me wonder whether they purposefully selected a sample that would give them a reasonably good range, or whether they did do consecutive.
And they could have said that, but what struck me is the age range was 31 to 68, and I felt that they've chosen younger patients to take part, because a lot of people that have treatment for breast cancer are older than that, and it's this prone position again, choosing younger patients that could actually easily get into a prone position.
Yeah. I think that's a very good point, and something when you're doing critical appraisal is to really look at the demographics of the sample, and I'm pleased you mentioned that, because there were a couple of things there. Kath, you mentioned about they did talk about the range of ages, BMI, and they did talk about the range of cup sizes. But what I felt was missing was in that in the results section or the methods section, a table of demographic data, so you could actually see the range, the individual. You could, from the breast volume sizes, kind of extrapolate, couldn't you, a little bit about the range of breast sizes, and I think there probably was a range from almost A cup to E and beyond, really, looking at those volume sizes.
7 cc to 1,000.
It's a big range, isn't it? And I think, I'm not sure, but I think 330 cc's is around a C cup size, roughly speaking. So it just gives a very vague range. But like you were saying, Denise, it is important to look at the sample and how applicable it is to the population of individuals that you would be treating in a department. So if the age range is primarily 50 and above, you would want to see that, because are they going to be able to get up and down off the platform?
Was it? The median age was 61 and a half, so it was still, obviously the 31 was a bit higher.
Yeah.
That's what
I was going to say.
Sorry.
That's all right. So just moving on to some other points on the checklist. I'm going to miss some of the things that aren't really necessarily applicable. So was there adequate concealment method? That's really for randomised studies, so that wasn't really applicable in this study. The subject of the investigators being blind about treatment allocation, again, due to the nature of the design and the repeated measures of it, and also the fact that the imaging was one of the tools for measuring the outcome, it's difficult to blind the assessment, because you would be able to tell whether they were prone or supine. It's a bit difficult to blind under that those conditions. Again, the treatment and control groups, were they matched at the start of the trial? Well, they act as their own control, so they are matched. That's why it's considered quite a strong experimental design in that respect. So if we move on to the outcomes that were measured, and this is a useful thing to look at when doing critical appraisal, is whether the outcomes they measure, do they measure them in a standard way that allows comparison across different research studies, and were they valid and reliable? What do people think about how they went about measuring the outcomes? Any views?
Yeah, I thought there was a good level of detail, so you kind of knew how they'd measured. And with regards to the setup errors that they measured, that was comparable with things that you might read in, say, the on-target and reports, definitions of systematic and random error. Sorry, I'm probably taking over what other people might say, but my only thoughts were around I would have liked more comment on the reliability of the surgical clip method of matching and measuring error, because it'd been good to sort of measure migration, if they had a method to sort of measure and distinguish between clip migration and...
Yeah. They did comment on that a little bit, didn't they? And sort of they made some estimations where they couldn't match 3, they'd use 2.
There is in the literature the work by Coles et al. About the use of clips as a method of matching, and it is considered the most accurate way. I wasn't totally clear how many pairs of clips each patient had, because in the work that Coles has looked at, I think they had 6 pairs double clips, and that was deemed what is required for accurate matching. So I agree with you, maybe a little bit more detail would have helped there.
I think perhaps more so than migration, because there was that subjectivity of if one clip didn't quite match, they sort of tried to do a best fit approach. Then what was there sort of an issue of inter-observer variability? It wasn't clear how many people were involved in taking the measurements for error.
So that, I felt that wasn't documented either. I don't know what other people felt, but I wasn't clear whether it was single or multiple observer, and if there was no assessment of inter-observer reliability, for example, if there was more than one person. And if there was one person, was there a test of intra-observer reliability? So did they go back and retest themselves? So for me, that would be a point of potential opportunity for bias.
I would say it's quite rare in studies like this to see an indication of the inherent error in measurement, and that where those errors are small, as they are, as absolute errors for something like this are being quoted, are actually quite small. If the variation in measurement, say 1 standard deviation, is at that level, then
the results are
meaningless.
Exactly, yeah.
And so that variation should be assessed and reported.
Yeah, I agree with you. Does anybody else have any views on that? I think we're all pretty agreed on that. So one thing we're probably all agreed at the moment in terms of the quality of the study is perhaps some limitations in the documenting or reporting of reliability of the measurements that were taken. If we move down the checklist, again, one of the questions is about attrition and how many of the participants dropped out. And I understand, my understanding was that only one didn't complete because of issues that arose with a second malignancy.
Did you utilise the first 10 fractions?
So I think on the whole, what we can say is that attrition was low, and therefore most of them completed and had fairly good data, fairly complete data for most of the cases. The next question isn't applicable. It's about whether subjects were analysed in the groups in which they were randomly allocated, but they were allocated. Obviously, they underwent both groups. And so we come to section 2 on the checklist, which is about how we individually would rate the overall quality assessment, the quality of the study, and what generally have people put here. I mean, Sign uses this coding of plus as being very high quality, single plus as okay with opportunities for bias, or a minus sign to indicate that there are some failings in the quality of the study that would mean that maybe perhaps the results or the conclusions cannot be used as well. So what do people think about what have people graded this individually?
I would still think it was okay. I think the design of it gives you that quality. It's the numbers, I think, that perhaps makes you think. You know,
I'd agree with that. The numbers, I think you can't move away from the numbers, and also the fact some of the limitations they do acknowledge, like because of how it was designed in terms of the same test on all patients, you couldn't compare that to. It mentioned it limited bias due to inter-patient differences, so you couldn't compare purely supine patients with purely prone patients. But they do acknowledge that. I think they do acknowledge the weaknesses in the study.
I mean, I personally have graded it as a single plus to kind of indicate that it has got some potentials for bias, like we've already mentioned. The sample size is small, but are not, as Rob, as you've said, not unusual for studies of this nature that are published. And some of the points we've talked about already in terms of consecutive sampling, the opportunity for bias there, the observer reliability not being documented. So do other people agree with that? Does anybody think it was less than that or better than that? Or
I'd given it 2 pluses.
Okay.
Because reading it and the repeated measures method I thought gave it good quality. But then after the discussion now, and the clips and the clip matching, and I think I would just now give it 1 plus.
Yeah.
One thing I'd say is that sometimes you have to be very cautious in how you interpret the results from studies like this. And going back to my point about the absolute differences between the two arms are going to be small. And so it's possible that you will see a statistically significant difference for a particular outcome, but that difference is going to be fairly meaningless from a clinical perspective.
Well, some of them are, but some of the we can go on to the results now and maybe pick up some of those points. I'd just like, if we go through the rest of the checklist, I'm not going to go through each point in detail, but basically you would just fill in each section based on the data that's in the article, and at the end there is an opportunity for you to write some notes about the results. And maybe if we can talk a little bit in general about the results and bring up some of those points in terms of clinical significance and some of the statistically significant things. So, for example, well, do you want to expand on that, Rob, in terms of some of the results that are reported? Because
yeah,
I mean, some of the I think there are some cases where in the results there's a lot of detail in those results tables. You look at some of the systematic errors and the random errors where they say there's no significant difference between the prone and the supine position for lateral movement or longitudinal movement, and that's acceptable. I mean, one point I would make there is you've only got 10 patients, so saying that there is no statistical significant difference between the accuracies doesn't necessarily mean a difference doesn't exist. It maybe just means that they haven't studied a big enough sample, and that in a bigger sample you would see a difference over a range of different patients and patient sizes. So that will be one.
I was actually going to be positive
yeah.
and say that they didn't necessarily in here focus on where there were sort of differences that were either statistically significant or slightly.
Okay.
In the conclusions, they focused on where the big differences were. So, for example, with DO2 for the ipsilateral lung, they pointed that out as being a big difference and related it to previous work they'd done.
Yeah.
Which I think is good, and you don't necessarily then focus on where the relatively small differences are.
Yeah.
I quite like how they've set out the results, because for me, I wouldn't say I was any sort of expert in looking at the quantitative research and statistical significance, but I could very clearly follow the way that it set it out. So for me, I looked at those outcomes in a general way, organs at risk, looked at the ipsilateral lung, and then that individual patients, and was able to glean from the p-values at least some sense of where there was differences or where there didn't appear to be differences. So I felt for me it was more of a commentary about the study, not that I could draw conclusions. I didn't feel expert enough to do that.
Yeah. But going back, sorry, Rob, just going back to your point about the clinical, some of the differences. Oh, go on then. Okay.
When you're looking at some of the shifts, for example, the errors in position, there were a few there that were statistically significant, but we're talking about a difference of 1 millimetre.
Are you on table 3?
This is table 3, yeah.
Yeah.
Which, again, 1 millimetre may be neither here nor there when you consider the inherent variation, uncertainty in measurement.
Absolutely, but some of the others are quite significantly different.
Yeah.
So just looking at the population error for prone and supine, so that's the bottom bit of the table. In the vertical axis, obviously for the prone patients, the difference between the prone and the supine is almost 5 millimetres. So that is clinically significant. But also going back to the other detail in table 3, some of the errors, if you look at individual patients, some of the errors are way above 3 millimetres, which is greater than the on-target recommendations or what is deemed to be acceptable or achievable with a standard breastboard technique. So it is useful, like you say, to have all this data because you can look at it in that at that individual level. So there are places where, and for me, I have to admit an absolute bias here because I don't necessarily like the prone technique. So I do pick out the bits where the prone technique didn't do quite so well. But a lot of, particularly in the vertical axis, looking at the individual patients, there are far more cases where the prone technique is less accurate, significantly, clinically, not just statistically, than the supine technique, if that makes sense.
Yeah.
Just one thing that's sort of made me think then during that discussion was this is very much why it's almost like a pilot study, isn't it?
It is,
because,
yeah.
And why it's important that they did show the individual data, because
Yeah.
you can look for possible, because
Yeah.
there is such variation between some that are very small differences and some that are very big. If this did have a bigger sample, they could have tried to do correlations, couldn't they, in terms of their analysis between things like breast size or BMI and the degree of movement, and tried to explain those inter-patient differences. So that's hopefully what you might go on and explore.
Yeah.
The other thing I wanted to just to mention was that it kind of relates back to the reliability and the sample size.
Yeah.
Would be that again in some of our guidance in the UK, like the On Target and the NRIG, it does actually recommend, doesn't it? Is it about a sample of 25
Yes, it does.
to accurately?
Yes, it does.
They recommend a sample of 25 as a minimum to accurately determine systematic
And randomised,
errors for
absolutely.
patient populations.
I think that's a very good point, and thanks for bringing that up. Actually, it's reminded me, and I think it is probably what we would see this more as a pilot or a feasibility type study. The other thing that's, I'm kind of going off a little bit with the discussion, but in their literature review at the beginning and also in the discussion at the end, they talk about this being quite unique and that they aren't aware of any other studies that have compared prone and supine in the same cases. And actually, there was a study at the Marsden by Kirby et al. I think it's either 2011 or 2010, fairly recently, that's published, that did exactly that. It's a study at the Marsden. So slightly, and it was in more patients actually. So it's slightly odd that they've said that and they're not aware of that study.
Was this originally written before that?
Well,
this was in
it's published in
submitted in 2010.
Yeah. Well, you would expect them to know about it going on, because it will the study at the Marsden will have been a registered clinical trial. So, it might not be published data, but their work came out before this one. So you would think it would have had to have been updated. Is there any other issues you want to raise about any of the design or the discussion or the results?
Sorry, Anne.
Something
Sue, you go
that
next.
popped in my mind when you were just talking about the fact that it would be it has been a useful sort of pilot, if you like, looking at how in future studies you could maybe recruit older patients perhaps, or different groups of patients, which possibly could result in because of the error with the vertical movement with prone patients, more elderly patients, you might find that the results will be that there will be more movement and more need to reposition patients, which might mean that the technique isn't appropriate for that group of patients. But because they weren't recruited in the pilot study, it'd be difficult to
You would certainly imagine
measure that.
impacting upon the setup time, wouldn't you,
Yeah.
for elderly patients treated in the prone position.
I mean, we had a bit of a discussion this morning about this prone and actually reducing the respiratory cycle, and Sue said maybe they should try this with SBRT, the prone position, because they currently use the chest clamp, don't they, and backpack to immobilise the patient for that. And, is it applicable in other sites? It's maybe not right for breast. But
I think it is interesting that, isn't it? And that's been shown in other studies with the prone technique, that it does restrict respiratory movement, and in that respect it is a positive for the technique. But actually I wasn't clear, I might be wrong, but in this study I didn't really think that overall the movement was that much. Even in the supine position, the respiratory motion was quite low, and I didn't think it was necessarily clinically significant, the amount of movement that was there. And because just going back to clinically significant measurements that you were saying, I mean, the random errors, for the population random errors for both supine and prone are quite high. They're nearly about 7 millimetres in the lateral direction, which would indicate to me that there is a problem with reproducibility for both of them, really.
Well, the nature of breast treatment.
It is, and so it would indicate that some further work needs to be done in terms of reproducing the breast. But I suppose what this...
Support for all.
Yes, yes, plug for my own study. But I think it's interesting as well because they did use cone beam as well, didn't they? They used CT, which probably we don't get a feel for in a lot of departments, maybe in the UK, because of the types of imaging that we do. Some centres will be using cone beam CT to analyse their breast setups, but not very many, I suspect. And so you might miss that kind of level
it was
breast
useful
movement.
to show how you could, the benefits of that type of imaging over I know
standard
that wasn't the purpose
yeah.
of the study, but it was a useful article to demonstrate what errors you can see with a 3D imaging.
If I can just bring the discussion to a close, because I think we've raised quite a lot of detail there. And maybe we could go around the room again, start with you again, Sue, if that's all right. So would your initial assessment of the article and the study, has it changed following this discussion, or do you still feel the same about your initial assessment?
I still feel the same about the assessment. I still think it's a good study. I think if the study was to be reproduced, I think there'll be areas that could be improved, particularly around the inter-rater reliability, measurement and so on.
Okay, thank you. David, what do you think?
The same, really. I mean, after the talk here, I've not really changed my opinion on it. I do think it's a decent article. It's impacted upon by the size of the study over all times.
Yeah. Denise?
Yeah, I feel the same. I think the discussion for me has been great in actually understanding the paper even more so, because you're hearing different perspectives on it. But I think generally the level of quality I feel is the same.
And what do you think?
I think it's reaffirmed my original thoughts that it could act as a good pilot study. And like the discussion that we've had has reinforced that.
Okay. Kath?
Yeah, I still think the same as well. I think it was a well-conducted study, so reliable in that sense, but just like with any paper you review, there's always going to be variables that you have to consider when looking at the significance of the results. And so just on that point, actually, sorry, just to raise one more thing, the only other thing I picked up on in terms of another variable was with the measurement of treatment time. And again, it would have been nice to just briefly know how many radiotherapists were involved during the course of the study in taking note, and how experienced they were,
and whether that had an impact.
That will have impacted on. It's just little things, isn't it, that you sometimes need to know just to sort of be able to comment more on the significance of the results you're reporting on. If you were doing an assignment on it,
if it's a research study, it might have been done in a research facility with the same radiographers.
Yeah.
Keely?
Same opinion, again, same as Denise. I think it's really good to talk about it because you pick up other people's perspectives, and I sort of had a set way of how I was approaching the article, and then having listened to your opinions, I think it's probably made me a bit more favourable towards it. I think sometimes, I don't know if anybody else, but if you're asked to critically analyse something, I always think, I'm going to be critical, and you sort of pull it to bits, and then sometimes if you hear someone else saying, oh, actually that was really good, and you think, oh yeah, you kind of forget sometimes to pick up on the good things, so I think that was beneficial.
I think that's a really good point to make. There's too much of an emphasis, I think, on trying to pull it to pieces and shred it.
Yeah, and it's not about that, is it? It's about...
Not at all.
No. Amy, any thoughts? Final thoughts?
Yeah, I agree. I think it would be good for a pilot study. It does need more, but I still don't like the fact it's the same patients sometimes.
We've not convinced them. Despite the evidence.
Not from a method, not from a method point of view, but from from the effort point of view, I just don't like the idea of it.
Well, you can address that to the ethics board of Ghent University Hospital.
Robert, any last comments from you?
No, I feel the same, but it was really good to have additional specific insight from yourself with regards to the general topic. Obviously, you're an expert in this, and Kath's points about the reproducibility of sort of getting an expert opinion on that with regards to other research. So it's good to when you are reviewing to think about what you know and what you don't know.
Yeah.
So,
I think a good place to end this is we hope it's been useful for you in terms of how we've gone about this critical appraisal. But I think a really good point to end on is what Rob's just said and Keely really is that critical appraisal isn't necessarily about criticising a piece of work. It's about trying to understand where there is potential for bias that may affect the results and how those are applied. And really we do have to consider all the positive aspects of this study. And actually, although we've been saying a lot of the time it's only 10 patients, the amount of data that accumulates for those 10 patients over the 25 fractions or however many it was is absolutely huge, and we mustn't underestimate that. So it is important to accentuate all the positives, but to house it in the fact that the opportunities for bias possibly in the design.
Oh, sorry.
Yeah.
One thing, I'm sorry, but I just think it might be important. I've not used the sign tool myself personally before. I've advised my students to use it before, and I know that it's absolutely essential to do this when you're doing the systematic review type research, but I actually found it much quicker to appraise this article using a tool like this than what I would do just trying to do my own appraisal of an article. And so and it really focuses your appraisal on the important things that you would then expect a student hopefully to comment on, even in an assignment for a module leading up to their dissertation. So I just wanted to sort of add my perspective on the process, and that it wasn't really that, didn't take that long.
So it's a helpful tool to kind of remind you perhaps of things to look for and
I think
to comment on.
The important thing is to appreciate, if you're going to report on results within your assignment, we simply want some comment on what you think of their reliability and validity at the end of the day, don't we? And some comment on their significance, and I think this kind of questioning does really help to focus on those things.
Okay.
Sorry.
Thank you for that, Kath. So we'll end this podcast here, and hope you found this useful.